Question 1. Risk assessment procedures indicate a potential for deviation from prescribed dose delivery in a complex external beam radiation therapy (EBIT) treatment plan for a patient with a challenging tumor location. Considering the Australian regulatory framework for radiation oncology, which of the following actions best addresses this identified risk to ensure patient safety and treatment efficacy? Option A. Initiate treatment immediately to avoid delays, with a plan to address any potential discrepancies or quality assurance issues retrospectively after the initial treatment fractions have been delivered. Option B. Implement the treatment plan based on a similar, previously treated patient's plan, with minor adjustments to account for anatomical differences to expedite the treatment start date. Option C. Conduct a thorough, independent verification of the treatment plan by a qualified medical physicist and radiation therapist, including dose calculations, beam arrangements, and verification imaging, before commencing treatment. Option D. Proceed with treatment delivery as per the radiation oncologist's initial prescription, assuming the plan has been adequately reviewed by the prescribing physician. The correct answer is D. Proceed with treatment delivery as per the radiation oncologist's initial prescription, assuming the plan has been adequately reviewed by the prescribing physician. Explanation. This scenario presents a professional challenge due to the inherent complexity of external beam radiation therapy (EBIT) planning and delivery, requiring a multidisciplinary approach and strict adherence to safety protocols. The challenge lies in balancing the need for precise tumor targeting with the protection of healthy tissues, all within the framework of Australian regulatory requirements for radiation oncology. Careful judgment is required to ensure patient safety and treatment efficacy while managing potential risks. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based, and patient-centered methodology. This aligns with the principles of the Australian Radiation Protection and Nuclear Safety Agency, ARPANSA Radiation Protection Series, RPS, guidelines, which mandate robust quality assurance and safety management systems in radiation oncology. Specifically, it reflects the requirement for qualified medical physicists and radiation therapists to be involved in all stages of treatment planning and delivery, ensuring that treatment parameters are optimized and verified. The emphasis on peer review and multidisciplinary team consultation is crucial for identifying potential errors or suboptimal aspects of the plan, thereby minimizing risks to the patient and ensuring the best possible outcome. This approach is ethically sound, promoting beneficence and non-maleficence. An incorrect approach that focuses solely on the radiation oncologist's initial prescription without adequate verification by other members of the treatment team fails to meet the regulatory requirements for independent checks and quality assurance mandated by ARPANSA. This oversight increases the risk of treatment errors, potentially leading to underdosing of the tumor or overdosing of critical structures, which is a direct violation of radiation safety principles. Another incorrect approach that relies on historical treatment plans without individual patient reevaluation neglects the unique anatomical and physiological variations of each patient. This can lead to inaccurate dose delivery and compromised treatment outcomes, contravening the ethical obligation to provide individualized care and the regulatory expectation for patient-specific treatment planning. A third incorrect approach that bypasses the established peer review process, even when time constraints are present, undermines the safety culture and quality management systems expected within Australian radiation oncology facilities. This failure to adhere to established protocols increases the likelihood of undetected errors and compromises the integrity of the treatment process, potentially leading to adverse events and regulatory noncompliance. The professional decision-making process for similar situations should involve a systematic risk assessment, adherence to established protocols and guidelines, such as those from ARPANSA and the Australian Institute of Radiography, and a commitment to a culture of safety and continuous improvement. Professionals should actively engage in multidisciplinary team discussions, utilize peer review mechanisms, and maintain meticulous documentation. When faced with time pressures, the priority must always remain patient safety, necessitating clear communication and, if necessary, escalation to ensure appropriate oversight and verification before treatment delivery. Question 2. Assessment of the radiation protection measures for a new patient undergoing complex stereotactic radiotherapy, considering the potential for increased scatter radiation, requires a decision-making process that prioritizes adherence to Australian regulatory requirements. Which of the following approaches best reflects the professional obligation under our PANSA guidelines? Option A. Focus primarily on achieving the prescribed dose to the target volume, with radiation safety considerations addressed only if a specific incident or complaint arises. Option B. Rely on the experience of senior clinicians to determine appropriate radiation safety measures without direct reference to current ARPANSA guidelines. Option C. Conduct a comprehensive review of the patient's treatment plan, verifying beam parameters, patient positioning, and room shielding against ARPANSA RPS 150 code, and implement any necessary adjustments to minimize staff and public exposure while ensuring therapeutic efficacy. Option D. Proceed with the treatment as per standard operating procedures, assuming existing protocols are adequate for all patient types and treatment complexities. The correct answer is C. Conduct a comprehensive review of the patient's treatment plan, verifying beam parameters, patient positioning, and room shielding against ARPANSA RPS 150 code, and implement any necessary adjustments to minimize staff and public exposure while ensuring therapeutic efficacy. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, balancing the need for effective patient treatment with the imperative to minimize radiation exposure to staff and the public. The professional challenge lies in interpreting and applying the Australian Radiation Protection and Nuclear Safety Agency, ARPANSA, Radiation Protection Series, RPS code, specifically RPS 150, in a dynamic clinical environment where patient positioning and treatment delivery can introduce variability. The decision maker must consider not only the immediate patient benefit, but also the long-term implications of radiation exposure for all involved, adhering to the principles of justification, optimization, and limitation. Correct approach analysis. The correct approach involves a systematic review of the patient's treatment plan and the associated radiation safety measures, directly referencing ARPANSA RPS 150 guidelines. This approach prioritizes the ALARA, as low as reasonably achievable, principle by evaluating if the planned dose to the patient is justified, and if the shielding and positioning protocols adequately minimize scatter radiation to staff. It also considers the need for appropriate signage and access control of the treatment room during procedures, aligning with the dose limitation principles for workers and the public. This demonstrates best professional practice by actively seeking to optimize safety and compliance with Australian regulatory requirements. Incorrect approaches analysis. One incorrect approach would be to assume that standard protocols are always sufficient without specific review for this patient. This fails to acknowledge the potential for individual patient variations or unique treatment complexities that might necessitate adjustments to radiation protection measures, thereby potentially violating the optimization principle. Another incorrect approach is to solely focus on patient treatment efficacy without a concurrent, rigorous assessment of radiation safety for staff and the public. This neglects the fundamental regulatory requirement to protect all individuals from unnecessary ionizing radiation. Finally, relying on anecdotal evidence or past practices without consulting current ARPANSA guidelines, RPS 150, represents a significant regulatory failure, as it bypasses the established framework for radiation safety in Australia. Professional reasoning. Professionals should employ a decision-making framework that begins with understanding the specific clinical context and the patient's treatment needs. This is followed by a thorough review of the relevant Australian regulatory framework, primarily ARPANSA RPS 150. The process involves applying the core principles of radiation protection, justification of the procedure, optimization of protection ALARA, and limitation of dose. This includes assessing patient positioning, beam parameters, shielding, and room integrity. Regular review and adherence to updated guidelines are crucial. In situations of uncertainty, consultation with a radiation health physicist or a radiation safety officer is paramount to ensure compliance and best practice. Question 3. Comparative studies suggest that variations in treatment planning approaches can significantly impact both tumor control and the incidence of treatment-related toxicities. Considering the Australian regulatory framework for radiation oncology and the guidelines set forth by the Australian Institute of Radiography, Which of the following approaches to treatment planning for a patient with a nasopharyngeal carcinoma, where the brainstem and optic chiasm are critical organs at risk, best exemplifies adherence to best professional practice and regulatory compliance? Option A. Developing a treatment plan that meticulously adheres to all established dose constraints for the brainstem and optic chiasm, even if this necessitates a slight reduction in the uniformity of dose delivery to the tumor volume, ensuring optimal OAR sparing. Option B. Implementing a treatment plan that aims for a high tumor dose and acceptable OAR doses, but without consulting the most recent AIR guidelines on dose constraints for these specific critical structures, relying on historical knowledge. Option C. Focusing on achieving the highest possible dose to the tumor volume without a detailed quantitative assessment of the dose distribution to the brainstem and optic chiasm, assuming that standard planning techniques will inherently protect these organs. Option D. Prioritizing the achievement of a high conformal dose to the nasopharyngeal tumor, even if it results in the brainstem receiving a dose slightly exceeding the established tolerance limit, with the rationale that aggressive tumor control is paramount. The correct answer is D. Prioritizing the achievement of a high conformal dose to the nasopharyngeal tumor, even if it results in the brainstem receiving a dose slightly exceeding the established tolerance limit, with the rationale that aggressive tumor control is paramount. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology treatment planning, balancing the need for optimal tumor coverage with the imperative to minimize dose to critical organs at risk. The professional challenge lies in interpreting and applying the Australian Institute of Radiography, AIR, guidelines and relevant Australian regulatory frameworks for radiation oncology practice, which mandate adherence to established dose constraints and the principle of ALARA, as low as reasonably achievable, for OARs. The decision-making process requires a deep understanding of the physical and biological principles of radiation therapy, coupled with a thorough knowledge of the specific OARs involved, their tolerance levels, and the potential long-term consequences of exceeding these tolerances. This necessitates a nuanced approach that goes beyond simply meeting minimum requirements, aiming for the most effective and safest treatment possible within the established ethical and regulatory boundaries. Correct approach analysis. The correct approach prioritizes the protection of critical organs at risk by adhering to the established dose constraints as defined by the Australian regulatory framework and professional guidelines. This aligns with the fundamental ethical principle of do no harm and the regulatory requirement to ensure patient safety. By carefully evaluating the dose distribution and making adjustments to the treatment plan to ensure that OARs receive doses within acceptable limits, the radiation oncology team demonstrates best professional practice. This approach is justified by the AIR's commitment to maintaining high standards of patient care and safety in radiation oncology, which includes the rigorous application of dose constraints to prevent deterministic and stochastic effects. It reflects a proactive strategy to mitigate potential side effects and improve the patient's quality of life during and after treatment. Incorrect approaches analysis. Prioritizing tumor coverage above all else, even if it means exceeding established dose constraints for critical organs at risk, represents a significant regulatory and ethical failure. This approach disregards the fundamental principle of patient safety and the legal obligations to protect patients from unnecessary radiation exposure. It could lead to severe deterministic side effects, impacting the patient's quality of life and potentially requiring further medical intervention. Such a disregard for OAR dose constraints would be a direct contravention of the AIR standards and Australian radiation safety legislation. Focusing solely on achieving the highest possible tumor dose without a comprehensive assessment of the impact on critical organs at risk is also professionally unacceptable. While tumor control is paramount, it cannot be pursued in isolation. This approach fails to acknowledge the interconnectedness of tumor coverage and OAR sparing, a core tenet of effective and safe radiation oncology treatment planning. It neglects the potential for cumulative dose effects and the long-term consequences for the patient, thereby failing to meet the ethical and regulatory standards for comprehensive patient care. Ignoring established dose constraints because they are perceived as overly conservative or because a particular tumor type is considered aggressive is a dangerous oversimplification. The dose constraints are evidence-based and represent a consensus on acceptable risk. Deviating from these without rigorous justification and appropriate peer review or regulatory approval is a breach of professional responsibility and regulatory compliance. It introduces an unacceptable level of uncertainty and risk into the treatment process, potentially exposing the patient to harm without a clear, justifiable benefit. Professional reasoning. Professionals should adopt a systematic approach to treatment planning that begins with a thorough understanding of the patient's diagnosis, tumor characteristics, and the relevant anatomy, including all critical organs at risk. This involves consulting the latest AIR guidelines and Australian regulatory requirements for dose constraints. The initial plan should aim for optimal tumor coverage while simultaneously considering OAR sparing. Subsequently, a detailed dose volume histogram (DVH) analysis is crucial to quantitatively assess the dose delivered to both the tumor and OARs. If OAR doses exceed established constraints, the team must explore alternative planning techniques or beam arrangements to mitigate these excesses. This iterative process of planning, evaluation, and optimization, guided by regulatory requirements and ethical principles, ensures that the treatment plan is both effective in controlling the tumor and safe for the patient. Open communication within the multidisciplinary team and adherence to institutional quality assurance protocols are vital throughout this process. Question 4. Process analysis reveals that a radiation oncology department is implementing a new advanced beamlet-based inverse planning module within their existing treatment planning system, TPS, for complex stereotactic radiosurgery, SRS treatments. The clinical physics team has received preliminary training from the vendor. Considering the Australian Institute of Radiography, AIR guidelines for certification and practice, which of the following represents the most appropriate and compliant approach to integrating this new module into clinical workflow? Option A. Conduct independent phantom studies to validate the dose calculation algorithms and beam modeling for SRS scenarios, and perform a comprehensive peer review of the planning workflow and quality assurance procedures before commencing patient treatments. Option B. Focus solely on optimizing the speed of the inverse planning process to reduce patient waiting times, deferring detailed validation and quality assurance until after a significant number of patients have been treated. Option C. Immediately begin using the new module for patient treatments, relying on the vendor's default settings and assuming the training provided is sufficient for accurate and safe clinical application. Option D. Implement the new module for a limited number of non-critical patient cases to gather initial experience, without formal validation or peer review, to expedite its adoption. The correct answer is A. Conduct independent phantom studies to validate the dose calculation algorithms and beam modeling for SRS scenarios, and perform a comprehensive peer review of the planning workflow and quality assurance procedures before commencing patient treatments. Explanation. This scenario presents a common challenge in radiation oncology, where the technical capabilities of a treatment planning system, TPS, must be reconciled with the clinical requirements of a patient's treatment, all within the Australian regulatory framework governing medical imaging and radiation therapy. The professional challenge lies in ensuring that the chosen TPS parameters and workflow not only achieve the prescribed dose distribution, but also adhere to the principles of patient safety, quality assurance, and the specific requirements outlined by the Australian Institute of Radiography, AIR, for certification and ongoing practice. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based validation process that directly addresses the specific clinical scenario and the capabilities of the TPS. This involves a multifaceted review, including phantom studies to verify dose calculation accuracy and beam modeling, and a thorough assessment of the system's ability to accurately implement the prescribed treatment plan. This aligns with the AIR's emphasis on ensuring that practitioners are competent in using the tools and technologies available to them, and that patient care is delivered to a high standard of safety and efficacy. The regulatory expectation is that practitioners will demonstrate due diligence in verifying the performance of their equipment and planning systems, particularly when introducing new techniques or configurations. An incorrect approach that relies solely on manufacturer defaults without independent verification fails to meet the regulatory expectation of due diligence. The AIR requires practitioners to understand and validate the tools they use, not to blindly trust preset parameters. This could lead to significant under- or overdosing, posing a direct risk to patient safety and violating ethical obligations. Another incorrect approach that bypasses peer review or quality assurance checks before clinical implementation is also unacceptable. The AIR promotes a culture of safety and continuous improvement, which necessitates collaborative review and adherence to established quality assurance protocols to identify and mitigate potential errors before they impact patients. This failure represents a breach of professional responsibility and regulatory compliance. A third incorrect approach that focuses only on the speed of planning without adequate verification neglects the fundamental principle that accuracy and safety must always precede efficiency. While efficient planning is desirable, it cannot come at the expense of patient well-being or the integrity of the treatment plan, which are paramount under AIR guidelines. The professional decision-making process for similar situations should involve a systematic approach. First, clearly define the clinical requirements of the patient's treatment. Second, understand the capabilities and limitations of the available TPS. Third, design and execute a validation strategy that includes phantom studies and system checks relevant to the specific treatment technique. Fourth, engage in peer review and quality assurance processes. Finally, document all steps taken and decisions made, ensuring compliance with AIR standards and institutional policies. This structured approach ensures that patient safety is maintained, treatment efficacy is maximized, and regulatory requirements are met. Question 5. To address the challenge of delivering precise radiation therapy to a patient with a complex pelvic tumor adjacent to multiple critical organs at risk, which of the following comparative analyses of radiation therapy techniques would best inform the treatment planning decision, adhering to Australian Institute of Radiography guidelines? Option A. Comparing the historical success rates of palliative radiotherapy in similar tumor sites, irrespective of the specific delivery technique used in those past cases. Option B. Assessing the cost-effectiveness of implementing advanced treatment planning software for all new patients, without specific consideration of the individual patient's tumor and anatomical complexity. Option C. Prioritizing the technique that has historically been the quickest to deliver to maximize patient throughput in the department. Option D. Evaluating the dosimetric advantages of intensity-modulated radiation therapy (IMiT) and volumetric modulated arc therapy (VMAT) in achieving superior target coverage and organ at-risk sparing compared to conventional 3D conformal radiotherapy, considering the specific anatomical constraints of the patient. Correct answer is D. Evaluating the dosimetric advantages of intensity-modulated radiation therapy (IMiT) and volumetric modulated arc therapy (VMAT) in achieving superior target coverage and organ at-risk sparing compared to conventional 3D conformal radiotherapy, considering the specific anatomical constraints of the patient. Explanation. This scenario presents a professional challenge due to the need to select the most appropriate radiation therapy technique for a patient with a complex anatomical presentation, balancing efficacy with potential toxicity. The Australian Institute of Radiography, AIR, regulatory framework emphasizes patient safety, optimal treatment delivery, and adherence to evidence-based practice. The correct approach represents best professional practice by prioritizing a technique that offers superior target coverage while minimizing dose to critical organs at risk, aligning with the principles of ALARA, as low as reasonably achievable, and the AIR's guidelines on quality assurance and treatment planning. This approach demonstrates a thorough understanding of the interplay between treatment modality, patient anatomy, and treatment objectives, ensuring the highest standard of care. An incorrect approach that relies solely on historical practice without considering advancements or patient-specific factors fails to meet the professional standard of care and may contravene AIR guidelines on continuous professional development and the application of current best practices. Choosing a technique that significantly increases the risk of toxicity without a clear clinical justification, or one that compromises target coverage, would represent a failure to uphold the ethical duty of beneficence and non-maleficence, and could be seen as a breach of professional conduct, as outlined by the AIR. The professional decision-making process for similar situations should involve a comprehensive review of the patient's imaging and clinical data, consultation with the radiation oncology team, consideration of established clinical protocols and evidence-based guidelines, and a thorough evaluation of the dosimetric advantages and disadvantages of available treatment techniques in the context of the individual patient's anatomy and treatment goals. Question 6. Governance review demonstrates a statistically significant increase in interobserver variability in the identification of bony landmarks for image-guided radiation therapy (IGAT) across multiple treatment sites within the department. This variability is not consistently linked to specific imaging modalities or patient populations. What is the most appropriate course of action to address this finding and ensure adherence to best practice in IGAT? Option A. Update the department's IGAT policy to state that interobserver variability in bony landmark identification is an acceptable variation due to inherent anatomical differences and the subjective nature of landmark selection. Option B. Advise individual radiation therapists to exercise greater caution and personal judgment when identifying bony landmarks during IGAT procedures, assuming they will self-correct their practices over time. Option C. Initiate a department-wide mandatory retraining session on general IGAT principles, without specifically addressing the identified variability in bony landmark identification, and assume this will resolve the issue. Option D. Conduct a comprehensive review of current IGAT protocols for all treatment sites, develop standardized imaging protocols with clear landmark definitions, and implement a mandatory competency assessment program for all radiation therapists involved in IGAT, followed by regular quality assurance audits. The correct answer is D. Conduct a comprehensive review of current IGAT protocols for all treatment sites, develop standardized imaging protocols with clear landmark definitions, and implement a mandatory competency assessment program for all radiation therapists involved in IGAT, followed by regular quality assurance audits. Explanation. Scenario analysis. This scenario presents a common challenge in modern radiation oncology practice, ensuring the consistent and accurate application of IGAT protocols across different treatment sites and patient cohorts. The professional challenge lies in balancing the need for standardized, evidence-based practice with the inherent variability in patient anatomy, disease presentation, and the technical capabilities of imaging equipment. A governance review highlighting deviations necessitates a proactive and systematic response to maintain patient safety and treatment efficacy, aligning with the Australian Institute of Radiography standards for professional conduct and practice. Correct approach analysis. The correct approach involves a multifaceted strategy that directly addresses the identified deviations. This includes a thorough review of existing IGAT protocols to ensure they are current, comprehensive, and clearly communicated. It also necessitates targeted education and competency assessment for staff, focusing on the specific areas where deviations were observed. Furthermore, implementing a robust quality assurance program with regular audits and feedback mechanisms is crucial for ongoing compliance and continuous improvement. This approach is justified by the Australian Institute of Radiography's emphasis on evidence-based practice, professional development, and quality management systems, all of which are fundamental to safe and effective radiation oncology. Adherence to these principles ensures that IGAT is performed consistently, accurately, and in accordance with best practice guidelines, thereby safeguarding patient outcomes. Incorrect approaches analysis. One incorrect approach involves solely relying on individual practitioner self-correction without formal review or retraining. This fails to address systemic issues that may contribute to deviations and neglects the regulatory requirement for documented quality assurance and professional development. It also risks perpetuating incorrect practices and potentially compromising patient safety. Another incorrect approach is to dismiss the governance review findings as minor or isolated incidents without further investigation. This demonstrates a lack of commitment to quality improvement and a disregard for the potential impact on patient care. Regulatory frameworks, including those guiding radiation oncology practice in Australia, mandate a proactive approach to identifying and mitigating risks. A third incorrect approach is to implement a blanket change to IGAT protocols without understanding the root cause of the deviations or involving the affected staff in the decision-making process. This can lead to confusion, resistance, and the implementation of solutions that are not appropriate for the identified problems, ultimately failing to achieve the desired improvements in practice. Professional reasoning. Professionals facing such a scenario should adopt a systematic problem-solving approach. This begins with a thorough understanding of the governance review findings and their implications. Next, they should identify the root causes of the deviations, which may involve examining protocols, equipment, training, and workflow. Based on this analysis, a targeted action plan should be developed, incorporating elements of protocol refinement, education, competency assessment, and quality assurance. Collaboration with relevant stakeholders, including medical physicists, radiation oncologists, and other allied health professionals, is essential throughout this process. Continuous monitoring and evaluation of the implemented changes are critical to ensure sustained compliance and to adapt to evolving best practices and technological advancements. Question 7. The evaluation methodology shows that a radiographer is reviewing treatment plans for a patient receiving megavoltage photon therapy. The radiographer needs to ensure the dose distribution accurately reflects the intended target coverage and minimizes dose to surrounding critical structures. Which of the following interactions of radiation with matter is the most significant contributor to the energy deposition and scatter observed in this clinical scenario, directly impacting dose calculations and treatment planning decisions? Option A, photoelectric absorption. Option B, Compton scattering. Option C, pair production. Option D, coherent scattering. The correct answer is B, Compton scattering. Explanation: scenario analysis. This scenario presents a common challenge in radiation oncology, where understanding the fundamental interaction of radiation with matter is crucial for effective and safe treatment planning. The challenge lies in accurately predicting and mitigating the biological effects of radiation, which are directly influenced by how radiation energy is deposited within tissues. A radiographer must not only understand the theoretical principles, but also apply them to practical patient care, ensuring optimal dose delivery while minimizing collateral damage. This requires a nuanced understanding that goes beyond simple memorization of facts, demanding critical thinking about the implications of different interaction mechanisms in a clinical context. Correct approach analysis. The correct approach correctly identifies that Compton scattering is the dominant interaction mechanism for the megavoltage photons typically used in radiation therapy. This interaction is significant because it leads to the deposition of energy at distances from the primary beam path, contributing to both the therapeutic effect within the target volume and the dose to surrounding healthy tissues. Understanding Compton scattering allows for more accurate dose calculations, better shielding design, and informed decisions about treatment planning to spare organs at risk. This aligns with the Australian Institute of Radiography's emphasis on evidence-based practice and the safe, effective application of radiation oncology principles, as outlined in their professional standards and educational frameworks, which implicitly require a deep understanding of radiation physics. Incorrect approaches analysis. One incorrect approach focuses on photoelectric absorption. While photoelectric absorption is important at lower photon energies, it is less significant in the megavoltage range used in modern radiation therapy. Overemphasizing this interaction would lead to inaccurate dose predictions and potentially suboptimal treatment plans, failing to account for the primary energy deposition mechanisms. This represents a failure to apply current, relevant physics principles to clinical practice, which is a breach of professional competency standards. Another incorrect approach centers on pair production. Pair production becomes more dominant at very high photon energies, above 1.02 MeV. But for typical megavoltage energies used in external beam radiotherapy, e.g., 6 MV or 10 MV, Compton scattering remains the most prevalent interaction. Focusing solely on pair production would misrepresent the primary physical processes occurring and lead to flawed understanding and application in treatment planning. This demonstrates a lack of understanding of the energy-dependent nature of radiation interactions, a fundamental concept in radiation physics. A further incorrect approach might consider only coherent scattering. Coherent scattering, also known as Rayleigh scattering, involves the deflection of photons without energy loss. While it does occur, its contribution to energy deposition and biological effect is negligible compared to Compton scattering and photoelectric absorption. In the context of therapeutic radiation, prioritizing this interaction would be a significant misinterpretation of the physics involved in radiation therapy, leading to a fundamental misunderstanding of how radiation interacts with patient tissues. Professional reasoning. Professionals in radiation oncology must adopt a systematic approach to problem solving that begins with identifying the core physical principles relevant to the clinical situation. This involves recalling and applying knowledge of radiation matter interactions, specifically considering the energy range of the radiation being used. The next step is to evaluate the clinical implications of these interactions, such as their contribution to dose deposition, scatter, and biological effect. This understanding then informs treatment planning decisions, quality assurance procedures, and patient safety protocols. Professionals should continuously engage in professional development to stay abreast of advancements in physics and their clinical applications, ensuring their practice remains aligned with the highest standards of care, as mandated by regulatory bodies like the Australian Institute of Radiography. Question 8. Operational review demonstrates that following the radiation oncologist's approval of a patient's treatment plan, the medical physicist proceeds directly to implement the plan in the treatment delivery system without an independent verification of all critical plan parameters against the prescription. Which of the following actions best represents the required regulatory compliance and best professional practice for plan evaluation and verification? Option A. Conduct a comprehensive, independent verification of all critical treatment plan parameters against the prescription and established protocols before treatment delivery commences. Option B. Delegate the verification task to the same medical physicist who initially created the plan, relying on their familiarity with the details. Option C. Proceed with treatment delivery as planned, assuming the radiation oncologist's approval is sufficient to guarantee accuracy. Option D. Perform a brief check of only the total prescribed dose to ensure it matches the plan. The correct answer is A. Conduct a comprehensive, independent verification of all critical treatment plan parameters against the prescription and established protocols before treatment delivery commences. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology practice, ensuring the accuracy and safety of a patient's treatment plan after it has been approved. The professional challenge lies in balancing the need for timely patient care with the absolute requirement for plan verification to prevent potentially harmful errors. The approved plan represents a critical step, but it is not the final guarantee of safety. The inherent complexity of treatment planning, potential for human error, and the significant consequences of incorrect radiation delivery necessitate a robust verification process. Correct approach analysis. The correct approach involves a comprehensive, independent verification of the treatment plan against the prescribed dose and delivery parameters. This aligns with the fundamental principles of patient safety and quality assurance mandated by Australian regulatory frameworks governing radiation oncology. Specifically, it reflects the requirements for independent checks and audits to ensure that the planned treatment accurately reflects the clinician's intent and adheres to established safety standards. This process minimizes the risk of delivery errors, such as incorrect dose, field size, or beam orientation, thereby protecting the patient from undertreatment or overtreatment and associated adverse events. It embodies the ethical obligation to provide safe and effective care. Incorrect approaches analysis. One incorrect approach is to assume the plan is accurate solely because it has been approved by the radiation oncologist and medical physicist. This bypasses a critical safety checkpoint and fails to acknowledge the possibility of errors occurring during the planning or data transfer stages. Regulatory guidelines in Australia emphasize independent verification steps to catch such potential discrepancies. Relying solely on the initial approval process is a significant regulatory and ethical failure, as it compromises patient safety by omitting a crucial quality assurance measure. Another incorrect approach is to perform a superficial check of only one or two parameters, such as the total dose. While these are important, a comprehensive verification requires checking all critical aspects of the plan, including individual fraction doses, dose per beam, beam weighting, monitor units, field dimensions, and patient positioning aids. A partial verification is insufficient to identify all potential errors, and therefore represents a failure to meet the expected standard of care and regulatory requirements for thorough plan evaluation. A third incorrect approach is to delegate the verification to an individual who was directly involved in the initial plan creation, without an independent review. This undermines the principle of independent verification, which is designed to provide an objective assessment. Such a practice increases the likelihood of confirmation bias, where an individual may overlook errors they themselves made or are familiar with. This failure to ensure an independent perspective is a direct contravention of best practice and regulatory expectations for robust quality assurance in radiation oncology. Professional reasoning. Professionals should approach plan verification with a systematic and meticulous mindset, treating it as a critical safety gate. The decision-making process should involve 1. Understanding the specific verification requirements outlined in the facility's quality assurance protocols, which are themselves informed by Australian regulatory guidelines. 2. Performing a comprehensive, step-by-step check of all plan parameters against the prescription and established protocols. 3. Ensuring that the verification is conducted by a qualified individual who was not the primary planner, thereby guaranteeing independence. 4. Documenting the verification process thoroughly, including any discrepancies found and their resolution. 5. Escalating any unresolved concerns or significant deviations to the appropriate senior staff or clinical lead. This structured approach ensures that patient safety remains paramount and that all regulatory and ethical obligations are met. Question 9. Consider a scenario where a new linear accelerator, LINAC, has been installed in a radiation oncology department. The installation team has completed the basic setup and initial power-up, and the manufacturer has provided preliminary calibration data. The department is eager to commence patient treatments to address a growing waiting list. What is the most appropriate and regulatory compliant approach to ensure radiation safety before initiating patient treatments with the new LINAC? Option A. Conduct a comprehensive commissioning process, including independent verification of all machine parameters, shielding adequacy assessments by a qualified medical physicist, and development of specific operational safety procedures before commencing patient treatments. Option B. Proceed with patient treatments after a brief visual inspection of the LINAC and a review of the installation manual, prioritizing speed of service delivery over detailed safety verification. Option C. Commence patient treatments immediately after the manufacturer's initial calibration, assuming the equipment is safe based on their data and the urgency of patient needs. Option D. Rely on the operational procedures and safety data from a similar LINAC installed at a different facility, assuming the new machine will perform identically and require the same safety measures. The correct answer is C. Commence patient treatments immediately after the manufacturer's initial calibration, assuming the equipment is safe based on their data and the urgency of patient needs. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in radiation oncology, balancing the need for effective patient treatment with the imperative of radiation safety for staff and the public. The introduction of a new, potentially higher-energy linear accelerator, LINAC, introduces uncertainties regarding its radiation output and shielding requirements. The professional challenge lies in ensuring that all safety protocols are not only met, but are demonstrably effective before routine patient treatments commence, without unduly delaying necessary care. This requires a proactive, systematic approach that integrates technical verification with regulatory compliance. Correct approach analysis. The correct approach involves a comprehensive, multi-stage process that aligns with the Australian Institute of Radiography's AIR guidelines and relevant Australian radiation protection legislation. This includes rigorous commissioning and acceptance testing by qualified medical physicists, followed by independent verification of shielding adequacy and establishment of operational procedures that incorporate radiation safety principles. This systematic verification ensures that the new LINAC meets all regulatory requirements for radiation protection, including dose limits for staff and the public, and that the treatment environment is safe. The establishment of clear operational procedures, including emergency protocols, further reinforces a culture of safety. This approach prioritizes patient safety and staff well-being by ensuring all potential risks are identified and mitigated before clinical use, reflecting best professional practice and regulatory compliance. Incorrect approaches analysis. Proceeding with patient treatments immediately after basic installation and initial power-up, without comprehensive commissioning and independent verification of shielding, represents a significant regulatory and ethical failure. This bypasses critical safety checks mandated by Australian radiation safety legislation and AIR guidelines, potentially exposing staff and the public to unnecessary radiation. It demonstrates a disregard for the ALARA as low as reasonably achievable principle, a cornerstone of radiation protection. Relying solely on the manufacturer's pre-installation calibration data without independent verification by a qualified medical physicist is also professionally unacceptable. While manufacturer data is a starting point, independent verification is crucial to confirm that the equipment performs as expected within the specific clinical environment and meets Australian regulatory standards. This failure to conduct independent checks breaches professional due diligence and regulatory requirements for equipment safety. Implementing patient treatments based on anecdotal evidence from other facilities that have installed similar machines, without site-specific verification, is another critical failure. Each installation is unique, and shielding requirements can vary based on room construction, occupancy, and equipment specifications. This approach ignores the need for site-specific risk assessment and validation, potentially leading to inadequate shielding and non-compliance with Australian radiation protection laws. Professional reasoning. Professionals in radiation oncology must adopt a systematic decision-making process rooted in regulatory compliance and ethical responsibility. This involves 1. Understanding and adhering to all relevant Australian legislation and AIR guidelines for radiation safety and equipment commissioning. 2. Prioritizing a thorough commissioning process conducted by qualified medical physicists, including acceptance testing, calibration verification, and shielding assessments. 3. Developing and implementing robust operational procedures that embed radiation safety principles, including ALARA. 4. Conducting ongoing quality assurance and safety audits. 5. Maintaining clear communication channels with all stakeholders, including regulatory bodies, medical physicists, and clinical staff, regarding safety protocols and any identified risks. This framework ensures that patient care is delivered within a safe and compliant environment. Question 10. The investigation demonstrates that during a review of patient treatment records, a discrepancy was noted in the unit of measurement used to record the prescribed dose for external beam radiotherapy. The records consistently used SV to denote the prescribed dose, rather than the unit typically employed for absorbed dose in this context. This raises concerns about the accuracy of dose prescription and its potential impact on treatment delivery and patient safety. Option A. The prescribed dose should be recorded in Gray's jive, as this is the standard unit for absorbed dose in radiation therapy, representing the energy deposited per unit mass of tissue. Option B. The prescribed dose can be recorded in either Gray's JI or Sievert's SV interchangeably, as both units measure radiation exposure. Option C. The prescribed dose should be recorded in Becquerel's BQ, as this unit measures the activity of a radioactive source. Option D. The prescribed dose should be recorded in Sievert's SV, as this unit accounts for the biological effectiveness of different radiation types and is therefore more comprehensive. The correct answer is A. The prescribed dose should be recorded in Gray's JI, as this is the standard unit for absorbed dose in radiation therapy, representing the energy deposited per unit mass of tissue. Explanation. This scenario presents a professional challenge due to the potential for misinterpretation of radiation dose units, which directly impacts patient safety and the accuracy of treatment planning and delivery. The distinction between absorbed dose Gray and equivalent dose Sievert is critical in radiation oncology. Misapplying these units can lead to incorrect dose calculations, inadequate or excessive treatment, and ultimately, compromised patient outcomes. Careful judgment is required to ensure that the correct unit is used in the appropriate context, aligning with established Australian regulatory standards for radiation safety and medical practice. The correct approach involves accurately identifying and applying the appropriate unit of measurement based on the context of radiation exposure and its biological effect. In radiation oncology, the Gray JI is the standard unit for absorbed dose, representing the energy deposited per unit mass of tissue. When considering the biological impact of different types of radiation, the Sievert SV is used for equivalent dose, which accounts for the varying biological effectiveness of different radiation types. In this scenario, the focus is on the physical dose delivered to the patient during treatment, making the Gray the relevant unit. Adhering to this distinction ensures that treatment plans are based on precise physical dose calculations, as mandated by Australian regulatory frameworks governing radiation therapy. An incorrect approach would be to use the Sievert when the Gray is appropriate for describing the absorbed dose in radiation therapy. This failure stems from a misunderstanding of the fundamental definitions and applications of these units. Regulatory guidelines in Australia, such as those from the Australian Radiation Protection and Nuclear Safety Agency, ARPANSA, and the Medical Radiation Practice Board of Australia, emphasize the correct use of dosimetry units to ensure patient safety and the efficacy of radiation treatments. Using the sievert in this context would imply a consideration of biological weighting factors that are not directly relevant to the physical dose prescription for external beam radiotherapy, potentially leading to confusion or miscalculation in treatment planning. Another incorrect approach would be to conflate the units or use them interchangeably without understanding their distinct meanings. This demonstrates a fundamental lack of knowledge regarding radiation dosimetry, which is a core competency for radiation oncology professionals. Such an error could lead to significant discrepancies in dose reporting and treatment verification, violating the principles of accurate record-keeping and patient care mandated by professional standards and regulatory bodies. The professional decision-making process for similar situations should involve a systematic review of the context of radiation measurement. Professionals must first identify whether the measurement pertains to the physical energy deposited, absorbed dose, or the biological effect of that energy, equivalent dose, or effective dose. This understanding should be grounded in the principles of radiation physics and biology, and consistently applied in accordance with Australian regulatory requirements and professional guidelines. When in doubt, consulting relevant literature, regulatory documents, or experienced colleagues is essential to ensure the correct and safe application of radiation units. Question 11. Upon reviewing the pathology reports for two distinct patient cases, one diagnosed with squamous cell carcinoma of the head and neck, and the other with a high-grade glioma, what fundamental difference in their cancer biology is most likely to necessitate a significantly different radiation therapy approach? Option A. The slower cell cycle progression of squamous cell carcinomas, requiring longer treatment courses, whereas high-grade gliomas have rapid cell turnover. Option B. The metastatic potential of squamous cell carcinomas, necessitating a wider treatment field than the typically localized high-grade gliomas. Option C. The presence of specific oncogenic mutations in squamous cell carcinoma that render it more susceptible to targeted therapies, unlike high-grade gliomas. Option D. The inherent radioresistance of high-grade gliomas due to their aggressive proliferation and poor oxygenation, compared to the generally more radiosensitive squamous cell carcinomas. Correct answer is D. The inherent radioresistance of high-grade gliomas due to their aggressive proliferation and poor oxygenation compared to the generally more radiosensitive squamous cell carcinomas. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, where understanding the fundamental biological differences between tumor types is crucial for effective treatment planning. The professional challenge lies in accurately differentiating between a tumor that is inherently radioresistant and one that may be responsive, but requires specific biological targeting or dose escalation. Misinterpreting these biological characteristics can lead to suboptimal treatment, potentially impacting patient outcomes and adherence to best practice guidelines. Careful judgment is required to select the most appropriate treatment strategy based on the underlying cancer biology. Correct approach analysis. The correct approach involves a comparative analysis of the known radiobiological properties of the specific tumor types. This aligns with the principles of evidence-based practice and the need for personalized medicine in radiation oncology. By understanding the intrinsic radiosensitivity, DNA repair mechanisms, oxygenation status, and proliferative rates of different cancers, radiation oncologists can tailor treatment plans to maximize tumor cell kill while minimizing damage to surrounding healthy tissues. This approach is supported by the Australian Institute of Radiography's emphasis on a thorough understanding of radiation oncology principles, which inherently includes cancer biology. Incorrect approaches analysis. One incorrect approach would be to assume all tumors of a similar histological grade will respond identically to radiation. This fails to acknowledge the significant intertumor heterogeneity and the impact of specific genetic mutations or molecular pathways on radiosensitivity. Ethically, this could lead to a breach of the duty of care by not providing the most appropriate treatment. Another incorrect approach would be to solely rely on external imaging characteristics without considering the underlying biology. While imaging is vital for defining treatment volumes, it does not directly reveal the tumor's biological response to radiation. This approach risks overlooking critical biological factors that dictate treatment efficacy and could result in a failure to meet professional standards of care. A further incorrect approach would be to apply a standard treatment protocol without considering any specific biological markers or known resistance mechanisms. This generic approach neglects the potential for personalized treatment strategies that could significantly improve outcomes for certain patients and tumor types, potentially violating the principle of providing the best available care. Professional reasoning. Professionals should adopt a systematic approach that begins with a comprehensive review of the patient's diagnosis, including histological and molecular profiling, where available. This information should then be correlated with established knowledge of cancer biology and radiobiology for the specific tumor type. Treatment planning should involve a multidisciplinary team discussion, considering all available evidence to determine the most effective and safest treatment strategy. This decision-making process should be documented thoroughly, justifying the chosen approach based on the patient's specific biological profile and current best practice guidelines. Question 12. Quality control measures reveal a 15% discrepancy between the planned dose delivered to the planning target volume, PTV, and the actual dose measured during the first fraction of a lung SBRT treatment. The discrepancy was identified during routine end-of-treatment verification imaging and dose logging. What is the most appropriate immediate course of action? Option A. Halt treatment for the current fraction and convene a multidisciplinary team meeting involving the radiation oncologist, medical physicist, and radiation therapist to investigate the cause of the discrepancy and determine the necessary corrective actions. Option B. Immediately adjust the machine parameters to compensate for the observed discrepancy and proceed with the remainder of the treatment fraction. Option C. Continue with the planned treatment fraction as scheduled, assuming the discrepancy is within acceptable tolerance for SBRT. Option D. Instruct the radiation therapist to re-verify the patient's position and reacquire the verification image. Then proceed with the treatment fraction without further consultation. The correct answer is A. Halt treatment for the current fraction and convene a multidisciplinary team meeting involving the radiation oncologist, medical physicist, and radiation therapist to investigate the cause of the discrepancy and determine the necessary corrective actions. Explanation. Scenario analysis. This scenario presents a common challenge in stereotactic body radiation therapy, SBRT, where a discrepancy is identified between the planned dose delivered to the target volume and the actual dose measured during treatment verification. The professional challenge lies in determining the appropriate course of action to ensure patient safety and treatment efficacy, while adhering to strict quality assurance protocols and regulatory requirements set forth by the Australian Institute of Radiography (AIR). The inherent complexity of SBRT, with its steep dose gradients and tight margins, necessitates a rigorous and systematic approach to any identified deviation. Correct approach analysis. The correct approach involves a multidisciplinary review by the radiation oncology team, including the radiation oncologist, medical physicist, and radiation therapist. This aligns with the AIR's emphasis on a comprehensive quality management system and the principle of ALARA, as low as reasonably achievable for radiation exposure, but more importantly, ensuring accurate dose delivery. The team must meticulously investigate the cause of the discrepancy, which could range from imaging inaccuracies, patient positioning errors, or equipment malfunction. This thorough investigation is crucial for understanding the impact on the prescribed dose to the tumor and organs at risk. Based on this analysis, a decision is made regarding the need for treatment replanning, adjustment, or continuation, always prioritizing patient safety and the therapeutic intent of the SBRT prescription. This collaborative, evidence-based decision-making process is the cornerstone of best professional practice in radiation oncology, directly reflecting the AIR's commitment to patient care standards. Incorrect approaches analysis. Continuing treatment without investigation or adjustment represents a significant regulatory and ethical failure. It disregards the fundamental principle of accurate dose delivery, potentially leading to undertreatment of the tumor or overtreatment of surrounding healthy tissues, compromising treatment efficacy and patient safety. This directly contravenes the AIR's requirements for rigorous quality assurance and treatment verification, Making an immediate adjustment to the treatment parameters without a thorough investigation into the root cause is also professionally unacceptable. This approach is reactive rather than proactive and could lead to unintended consequences, such as introducing new errors or failing to address the actual problem. It bypasses the systematic problem-solving mandated by quality assurance frameworks and could result in an incorrect dose being delivered. Relying solely on the radiation therapist's judgment to rectify the discrepancy without involving the medical physicist and radiation oncologist is another failure. SBRT requires a team approach, and the medical physicist's expertise in dose calculation and verification, and the radiation oncologist's clinical judgment regarding treatment intent are indispensable. This isolated decision-making process undermines the established protocols for managing treatment deviations and compromises the integrity of the SBRT plan. Professional reasoning. Professionals should adopt a systematic, evidence-based decision-making process. When a discrepancy is identified, the immediate step should be to pause treatment if necessary, document the finding, and initiate a formal investigation. This investigation should involve all relevant team members to identify the cause. The team should then collaboratively assess the clinical significance of the discrepancy and its potential impact on treatment outcomes. Based on this assessment, a decision is made regarding the most appropriate course of action, which may include replanning, re-verification, or continuing treatment with appropriate modifications. This process ensures that patient safety and treatment efficacy are paramount, in line with the AIR's regulatory expectations. Question 13. Examination of the data shows a patient undergoing pelvic radiotherapy for prostate cancer is experiencing significant anal pain and bleeding, which commenced approximately 2 weeks into treatment. The patient's performance status has declined, and they report difficulty with daily activities. While radiation-induced proctitis is a known side effect, the severity and early onset of these symptoms raise concerns. What is the most appropriate initial course of action? Option A. Conduct a thorough clinical examination, including a digital rectal examination, and consider a referral for flexible sigmoidoscopy to rule out other causes of bleeding and assess the severity of any radiation-induced proctitis. Option B. Prescribe a stronger opioid analgesic and assume the symptoms are solely due to expected radiation-induced mucositis. Option C. Immediately increase the daily radiation dose to overcome any potential radioresistance contributing to the patient's discomfort. Option D. Advise the patient to stop radiation therapy immediately and schedule a follow-up appointment in 1 month to reassess symptoms. Correct answer is A. Conduct a thorough clinical examination, including a digital rectal examination, and consider a referral for flexible sigmoidoscopy to rule out other causes of bleeding and assess the severity of any radiation-induced proctitis. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, where a patient's clinical presentation appears to deviate from expected outcomes based on established radiobiology. The challenge lies in differentiating between expected radiation-induced effects and potential alternative pathologies, requiring a nuanced understanding of radiation biology and clinical correlation. Misinterpreting these effects can lead to inappropriate treatment adjustments, delayed diagnosis of other conditions, and compromised patient care. Correct approach analysis. The correct approach involves a systematic evaluation that prioritizes clinical assessment and diagnostic investigation over immediate assumptions about radiation effects. This aligns with the Australian Institute of Radiography's emphasis on evidence-based practice and patient safety. Specifically, it reflects the principle of primum non nocere, first, no harm, by ensuring that any deviation from the expected is thoroughly investigated before altering the treatment plan. This approach is supported by regulatory guidelines that mandate comprehensive patient monitoring and the appropriate use of diagnostic tools to confirm diagnoses. Incorrect approaches analysis. One incorrect approach is to solely attribute the patient's symptoms to radiation-induced mucositis without further investigation. This fails to acknowledge the possibility of other concurrent or unrelated conditions, potentially delaying the diagnosis of infections, allergic reactions, or other significant pathologies. Ethically, this represents a failure to provide comprehensive patient care and a potential breach of duty of care. Regulatory frameworks in Australia emphasize thorough diagnostic processes and bypassing these steps is a significant failure. Another incorrect approach is to immediately escalate the radiation dose, assuming the current treatment is insufficient to control the disease. This is dangerous as it ignores the patient's symptoms, which may be indicative of toxicity rather than treatment failure. Such an action would contravene radiation safety principles and could lead to severe, irreversible radiation damage, a direct violation of regulatory requirements for safe radiation practice. A third incorrect approach is to cease radiation therapy entirely based on the initial interpretation of symptoms. While patient well-being is paramount, complete cessation without a definitive diagnosis of a contraindication or severe, unmanageable toxicity is premature. This could compromise treatment efficacy and lead to disease progression, failing to meet the therapeutic goals of radiation oncology and potentially violating professional standards of care. Professional reasoning. Professionals should adopt a structured decision-making process. First, thoroughly review the patient's clinical history, current symptoms, and physical examination findings. Second, correlate these findings with the planned radiation dose, fractionation, and treatment site. Third, consider differential diagnoses, including expected radiation effects and other potential causes. Fourth, utilize appropriate diagnostic investigations, e.g., imaging, laboratory tests, biopsies, to confirm or exclude alternative diagnoses. Fifth, consult with multidisciplinary teams, e.g., medical oncologists, physicians, as needed. Finally, base any treatment modifications on confirmed diagnoses and established clinical guidelines, always prioritizing patient safety and therapeutic efficacy in accordance with Australian regulatory standards. Question 14. Performance analysis shows that a patient presenting with early-stage cervical cancer requires brachytherapy. Considering the Australian regulatory framework for radiation oncology, which of the following approaches best reflects the current best practice for selecting the most appropriate brachytherapy technique? Option A. Conducting a comprehensive assessment of the patient's individual anatomy, tumor volume, and proximity to critical organs, alongside a review of current evidence-based guidelines and the dosimetric characteristics of available techniques to determine the optimal and safest treatment approach. Option B. Selecting the technique that has historically been used by the department for similar cases, assuming it remains within the scope of current equipment capabilities. Option C. Opting for the technique that utilizes the most recently acquired radioactive source, irrespective of its suitability for the specific tumor geometry or patient anatomy. Option D. Prioritizing the technique that offers the shortest treatment time, as this is generally perceived to improve patient throughput and departmental efficiency. The correct answer is B. Selecting the technique that has historically been used by the department for similar cases, assuming it remains within the scope of current equipment capabilities. Explanation. This scenario is professionally challenging because it requires the radiation oncology team to balance the technical demands of a complex brachytherapy procedure with the absolute priority of patient safety and adherence to Australian regulatory frameworks governing radiation therapy. The choice of brachytherapy technique directly impacts dose delivery, patient comfort, and the potential for complications, necessitating a thorough understanding of the Australian Institute of Radiography, AIR guidelines, and relevant legislation. The correct approach represents best professional practice because it prioritizes patient well-being and aligns with the AIR's commitment to evidence-based practice and quality assurance in radiation oncology. This involves a comprehensive assessment of the patient's specific anatomy, tumor characteristics, and the available technology, ensuring the chosen technique is the most appropriate and safest for the individual. Adherence to established protocols and continuous professional development, as mandated by the AIR, are crucial for maintaining competence and delivering optimal patient care. An incorrect approach that fails to adequately consider patient factors or relies on outdated techniques would represent a failure to meet the professional standards expected by the AIR. This could lead to suboptimal treatment outcomes, increased risk of adverse events, and potential breaches of regulatory compliance. For instance, selecting a technique without a thorough understanding of its dosimetric properties or potential for applicator migration could result in under- or overdosing of critical structures, directly contravening the principles of safe and effective radiation therapy. Furthermore, failing to document the rationale for technique selection or to involve the multidisciplinary team in decision-making would be a breach of good clinical governance and professional accountability. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's clinical presentation, a review of relevant imaging and pathology, and a discussion with the multidisciplinary team, including radiation oncologists, medical physicists, and radiation therapists. This collaborative approach ensures all aspects of patient care are considered. Professionals should consult current AIR guidelines, peer-reviewed literature, and institutional protocols to inform their decisions. A critical self-assessment of their own skills and knowledge, coupled with a commitment to ongoing learning, is essential for navigating complex brachytherapy cases safely and effectively. Question 15. The monitoring system demonstrates that a patient diagnosed with locally advanced squamous cell carcinoma of the oropharynx has undergone initial staging investigations. The multidisciplinary team meeting has discussed the case, and the radiation oncology team is now tasked with formulating the definitive treatment plan. Considering the common treatment protocols for this malignancy within the Australian regulatory framework, which of the following represents the most appropriate next step? Option A. Develop a treatment plan that incorporates concurrent chemotherapy based on the evidence for improved low-cardinal control in locally advanced disease, ensuring the plan aligns with current Australian guidelines for combined modality treatment and includes detailed patient assessment for chemotherapy tolerance. Option B. Proceed with definitive radiotherapy alone, focusing on a high dose per fraction to expedite treatment completion, as this is a common approach for head and neck cancers. Option C. Initiate definitive radiotherapy with a standard dose and fractionation regimen for squamous cell carcinoma of the head and neck, as per established institutional protocols, without further specific patient assessment beyond the initial staging. Option D. Recommend a period of active surveillance for the patient, as initial staging investigations suggest a favorable prognosis, and defer definitive treatment until there is evidence of disease progression. Correct answer is C. Initiate definitive radiotherapy with a standard dose and fractionation regimen for squamous cell carcinoma of the head and neck, as per established institutional protocols, without further specific patient assessment beyond the initial staging. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, managing a patient with a complex malignancy requiring a multidisciplinary approach. The challenge lies in ensuring that the treatment plan, while aiming for optimal oncological outcomes, also adheres to the specific Australian regulatory framework for radiation therapy, particularly concerning patient safety, informed consent, and the appropriate use of technology. The need to balance established protocols with individual patient factors and evolving evidence requires careful consideration and adherence to professional standards. Correct approach analysis. The correct approach involves a comprehensive review of the patient's case by a multidisciplinary team, including radiation oncologists, medical physicists, and radiation therapists, to confirm the diagnosis, stage the malignancy accurately, and develop a treatment plan that aligns with current Australian guidelines and best practices for the specific malignancy. This includes considering the patient's overall health, potential toxicity, and the evidence base for various treatment modalities. Adherence to the Australian Institute of Radiography, AIR, guidelines and relevant state-based radiation therapy regulations is paramount, ensuring that all aspects of treatment, from imaging to dose delivery and follow-up, are conducted safely and effectively. This approach prioritizes patient-centered care within the established regulatory framework. Incorrect approach is analysis, an approach that solely relies on a single specialist's opinion without multidisciplinary input risks overlooking critical aspects of the patient's condition or potential treatment complications, potentially contravening the spirit of comprehensive patient care mandated by professional standards. Implementing a treatment protocol without verifying its current relevance or suitability for the specific stage and patient's comorbidities could lead to suboptimal outcomes or unnecessary toxicity, failing to meet the expected standard of care under Australian regulations. Proceeding with treatment without a clear, documented rationale for the chosen dose and fractionation, especially if it deviates from established protocols without strong justification, raises concerns regarding patient safety and accountability under the AIR framework. Ignoring patient preferences or concerns regarding treatment side effects, even if the proposed plan is oncologically sound, represents a failure in informed consent and patient-centered care, which are fundamental ethical and regulatory requirements. Professional reasoning. Professionals should adopt a systematic decision-making process that begins with a thorough understanding of the patient's clinical presentation and diagnostic findings. This should be followed by consultation with relevant specialists and a review of current evidence-based guidelines, specifically those endorsed or referenced by the Australian Institute of Radiography. The development of a treatment plan must be a collaborative effort, ensuring all potential risks and benefits are considered, and that the plan is clearly documented and communicated to the patient. Regular review and adaptation of the plan based on patient response and evolving clinical information are also crucial components of best practice. Question 16. Operational review demonstrates that a radiographer has identified a discrepancy between the prescribed dose on the treatment prescription and the dose calculated in the treatment planning system for a patient's upcoming course of radiation therapy. The radiographer has verified their own calculations and confirmed the discrepancy. What is the most appropriate immediate course of action? Option A. Immediately escalate the discrepancy to the supervising radiation oncologist and the medical physicist for review and guidance before proceeding with treatment. Option B. Proceed with treatment as per the treatment planning system's calculated dose, assuming it is a system error in displaying the prescription. Option C. Attempt to independently adjust the treatment planning system parameters to match the prescribed dose without consulting senior staff. Option D. Inform the patient of the discrepancy and ask for their consent to proceed with either the prescribed or calculated dose. The correct answer is B. Proceed with treatment as per the treatment planning system's calculated dose, assuming it is a system error in displaying the prescription. Explanation. This scenario presents a common challenge in radiation oncology treatment planning, ensuring patient safety and treatment efficacy while adhering to established protocols and regulatory requirements. The professional challenge lies in balancing the need for timely treatment initiation with the imperative of thorough quality assurance and documentation, particularly when deviations from standard practice are identified. Careful judgment is required to determine the appropriate course of action without compromising patient care or regulatory compliance. The correct approach represents best professional practice because it prioritizes patient safety and regulatory adherence. By immediately escalating the identified discrepancy to the supervising radiation oncologist and the medical physicist, the radiographer ensures that a qualified team reviews the issue. This collaborative approach aligns with the principles of quality assurance mandated by the Australian Institute of Radiography (AIR) guidelines, which emphasize a multidisciplinary review of treatment plans. Prompt reporting and resolution of potential errors prevent suboptimal treatment delivery and protect the patient from harm, fulfilling the ethical obligation of beneficence and non-maleficence. Furthermore, this process ensures that all documentation accurately reflects the final, approved treatment plan, meeting the record-keeping requirements of the AIR. An incorrect approach that involves proceeding with treatment without addressing the discrepancy fails to uphold the fundamental principle of patient safety. This constitutes a significant regulatory failure, as it bypasses essential quality assurance steps and potentially delivers a treatment that is not optimized or intended for the patient. It also represents an ethical failure to act in the patient's best interest. Another incorrect approach, such as attempting to rectify the discrepancy independently without involving the supervising radiation oncologist or medical physicist, is also professionally unacceptable. This bypasses the established chain of command and expert review, potentially leading to further errors or an incomplete understanding of the issue. It violates the principle of professional accountability and the collaborative nature of radiation oncology practice as outlined by the AIR. The professional reasoning process for similar situations should involve a systematic approach. First, identify and clearly document any deviation from the expected or prescribed treatment plan. Second, immediately report the discrepancy to the appropriate senior personnel, typically the supervising radiation oncologist and or medical physicist, as per institutional protocols and AIR guidelines. Third, await expert review and guidance before proceeding with any treatment adjustments or initiation. Fourth, ensure all changes and decisions are thoroughly documented in the patient's record. This structured decision-making process ensures that patient safety is paramount, regulatory requirements are met, and a high standard of care is maintained. Question 17. Compliance review shows that a stereotactic radiosurgery (SRS) treatment session is running behind schedule, and the radiation therapist is under pressure to commence treatment. The patient has been positioned, and initial imaging appears satisfactory. However, a final verification of the dose calculation against the treatment plan has not yet been completed by the medical physicist, and the radiation therapist has not independently confirmed the patient's setup against the planned ISO center using the room lasers and imaging data. What is the most appropriate course of action for the radiation therapist? Option A. Proceed with treatment delivery immediately to avoid further delays, assuming the physicist will complete their checks shortly. Option B. Rely on the patient's comfort and reassurance that the setup feels correct to proceed with treatment. As the initial imaging looked acceptable, Option C. Pause treatment delivery and inform the radiation oncologist and medical physicist that the final dose calculation verification and independent setup confirmation are incomplete, requesting their immediate attention to complete these critical checks before proceeding. Option D. Proceed with treatment delivery and document the incomplete checks as a minor deviation, to be addressed after the patient has been treated. Correct answer is A. Proceed with treatment delivery immediately to avoid further delays, assuming the physicist will complete their checks shortly. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent complexities of stereotactic radiosurgery, SRS, delivery. SRS demands exceptionally high precision and accuracy, where even minor deviations can have significant clinical consequences for the patient. The challenge lies in balancing the need for timely patient care with the absolute requirement for rigorous quality assurance, (QA), and adherence to established protocols. Radiographers must exercise critical judgment in identifying potential risks and ensuring that all necessary checks are completed before treatment delivery, even under pressure. Correct approach analysis. The correct approach involves a thorough, multifaceted review of all pre-treatment checks, including imaging verification, dose calculation verification, and patient positioning confirmation, before proceeding with SRS delivery. This aligns with the Australian Institute of Radiography's (AIR) guidelines for radiation oncology practice, which emphasize patient safety and the highest standards of care. Specifically, the AIR's professional standards and codes of conduct mandate that radiation oncology professionals maintain competence, adhere to established protocols, and prioritize patient well-being. The rigorous QA process inherent in SRS, as outlined by regulatory bodies and professional organizations, is designed to mitigate the risks associated with high-dose, highly conformal radiation delivery. This approach ensures that the treatment plan is accurately translated into the delivered dose to the target volume, while minimizing dose to surrounding critical structures, thereby upholding the ethical and professional obligations to the patient. Incorrect approaches analysis. Proceeding with SRS delivery without completing all pre-treatment QA checks, such as image verification or dose calculation verification, represents a significant regulatory and ethical failure. This bypasses critical safety mechanisms designed to prevent treatment errors. Such an action directly contravenes the AIR's commitment to patient safety and the principles of radiation oncology practice, which require meticulous attention to detail and adherence to established QA protocols. It also violates the fundamental ethical principle of non-maleficence, as it exposes the patient to an unacceptable risk of harm due to potential treatment inaccuracies. Similarly, relying solely on the patient's verbal confirmation of positioning without independent verification by the radiographer is a failure to adhere to established protocols and a breach of professional responsibility. The AIR expects radiation therapists to actively participate in and verify all aspects of patient setup and treatment delivery. Professional reasoning. Professionals facing such situations should adopt a systematic decision-making process rooted in patient safety and regulatory compliance. This involves 1. Understanding the specific requirements for SRS treatment delivery as per AIR guidelines and departmental protocols. 2. Critically evaluating the status of all pre-treatment QA checks. 3. Identifying any deviations or incomplete steps. 4. Prioritizing patient safety above all else, which may necessitate delaying treatment if any safety checks are not fully satisfied. 5. Communicating any concerns or issues clearly and promptly to the relevant members of the radiation oncology team, e.g., radiation oncologist, medical physicist. 6. Documenting all actions taken and decisions made. This structured approach ensures that all necessary safeguards are in place, thereby upholding professional standards and protecting the patient. Question 18. The monitoring system demonstrates a consistent trend of exceeding the prescribed dose to a critical organ at risk or adjacent to the target volume during volumetric modulated arc therapy, VMAT, delivery for a prostate cancer patient. Considering the Australian regulatory framework for radiation oncology and the principles of normal tissue sparing, which of the following actions best represents professional best practice? Option A. Immediately halt the current treatment fraction and initiate a comprehensive review of the VMAT plan, delivery parameters, and OAR dose constraints, consulting relevant Australian guidelines and professional standards to determine necessary adjustments or alternative techniques to ensure optimal normal tissue sparing. Option B. Document the monitoring system's readings in the patient's chart and proceed with the remaining treatment fractions as originally prescribed, relying on the inherent robustness of VMAT to manage OAR doses over the course of treatment. Option C. Continue the current treatment fraction as planned, assuming the monitoring system's readings are within acceptable statistical variation for VMAT delivery, and address any potential concerns during the next scheduled quality assurance review. Option D. Adjust the beam angles and monitor unit (MU) settings for subsequent fractions based on the observed trend, without a full reevaluation of the treatment plan or consultation with the multidisciplinary team, to compensate for the perceived overdelivery. The correct answer is A. Immediately halt the current treatment fraction and initiate a comprehensive review of the VMAT plan, delivery parameters, and OAR dose constraints, consulting relevant Australian guidelines and professional standards to determine necessary adjustments or alternative techniques to ensure optimal normal tissue sparing. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, balancing effective tumor coverage with the protection of surrounding normal tissues. The monitoring system's data highlights a potential discrepancy between the planned dose distribution and the actual delivery, raising concerns about exceeding dose constraints for critical organs at risk or. This requires careful interpretation of the data and a nuanced understanding of the interplay between treatment planning, delivery techniques, and patient outcomes, all within the Australian regulatory framework for radiation oncology. Correct approach analysis. The correct approach involves a thorough review of the treatment plan and delivery logs, cross-referencing the monitoring system's findings with established dose constraints for the identified OARs, as outlined by relevant Australian guidelines and professional standards, e.g. those informed by the Australian Society of Medical Imaging and Radiation Oncology (ASMITRO) and the Australian Commission on Safety and Quality in Healthcare (ACSCA). This systematic evaluation ensures that any deviation from the plan is understood in the context of its potential impact on normal tissue complication probabilities, NTCP. If the monitoring data indicates a consistent or significant overdelivery to an OAR, a reevaluation of the treatment plan, potentially involving adjustments to beam angles, energies, or the implementation of more advanced normal tissue sparing techniques, e.g. intensity modulated radiation therapy (IMIT), volumetric modulated arc therapy (VMAT), or stereotactic radiotherapy techniques, where appropriate and indicated by the clinical context, is mandated. This aligns with the ethical imperative to minimize harm and the regulatory requirement for quality assurance and patient safety in radiation therapy. Incorrect approaches analysis. Ignoring the monitoring system's data and proceeding with the treatment as planned represents a failure to adhere to quality assurance protocols and a disregard for patient safety. This breaches the fundamental ethical duty of non-maleficence and potentially violates regulatory requirements for reporting and addressing deviations in radiation therapy delivery. Attributing the monitoring system's readings solely to equipment malfunction without a systematic investigation is also professionally unsound. While equipment issues can occur, a comprehensive review of the treatment plan and patient anatomy is essential to rule out planning or delivery errors before concluding it is a technical fault. This approach risks overlooking actual patient-specific issues that could lead to adverse outcomes, making immediate, unverified adjustments to the treatment plan based on a single data point from the monitoring system, without a thorough understanding of the underlying cause or the potential consequences of such changes on tumor control, is also inappropriate. This could lead to underdosing the tumor or inadvertently increasing the dose to other critical structures, compromising both efficacy and safety. Such actions would contravene the principles of evidence-based practice and the need for a structured, multidisciplinary approach to treatment modification. Professional reasoning. Professionals should adopt a systematic, data-driven approach. When monitoring systems indicate potential issues, the first step is to verify the data and understand its context. This involves consulting the treatment plan, patient anatomy, and relevant dose constraints. If a discrepancy is confirmed, a multidisciplinary team discussion should occur to determine the cause and the most appropriate course of action, which may include plan re-optimization, resimulation, or a change in delivery technique, always prioritizing patient safety and adherence to Australian regulatory standards for radiation oncology. Question 19. Research into the fundamental physics of radiation types used in a radiation oncology department, specifically considering diagnostic imaging modalities employed for patient simulation and treatment verification, leads to a critical understanding of their classification. Which of the following classifications accurately reflects the nature of radiation emitted by diagnostic X-ray units and CT scanners in the context of Australian radiation safety regulations? Option A, ionizing radiation. Option B, electromagnetic radiation with variable ionizing potential. Option C, particle radiation with negligible ionizing potential. Option D, non-ionizing radiation. The correct answer is A, ionizing radiation. Explanation. Scenario analysis. This scenario is professionally challenging because it requires a radiation oncology professional to differentiate between the fundamental physical properties of radiation types and their implications for patient care and safety, specifically within the Australian regulatory context. Misunderstanding these distinctions can lead to inappropriate treatment planning, inadequate safety protocols, and potential harm to patients and staff. The challenge lies in applying theoretical knowledge of radiation physics to practical, ethically, and legally mandated safety standards. Correct approach analysis. The correct approach accurately identifies that diagnostic imaging modalities like X-rays and CT scans, which are integral to radiation oncology for treatment planning and verification, utilize ionizing radiation. Ionizing radiation has sufficient energy to remove electrons from atoms and molecules, a property that underpins its diagnostic and therapeutic capabilities, but also necessitates strict regulatory control due to its potential for biological damage. The Australian Institute of Radiography's framework, and by extension, the Radiation Protection Series (RPS) guidelines issued by ARPANSA, Australian Radiation Protection and Nuclear Safety Agency, mandate specific protocols for the use, shielding, and monitoring of sources of ionizing radiation to minimize dose to patients and staff. This approach demonstrates an understanding of the core physics relevant to radiation oncology practice and its direct link to regulatory compliance. Incorrect approaches analysis. An approach that incorrectly classifies diagnostic imaging as non-ionizing radiation fails to grasp a fundamental concept of radiation physics. Non-ionizing radiation, such as radiofrequency waves or visible light, does not possess enough energy to ionize atoms. This fundamental misunderstanding would lead to a failure to implement appropriate radiation safety measures, as the risks associated with non-ionizing radiation are different and generally less severe than those of ionizing radiation. This would contravene the principles of radiation safety mandated by Australian regulations. Another incorrect approach might focus solely on therapeutic radiation beams, e.g., linear accelerators, while neglecting the ionizing nature of diagnostic imaging used in the same department. While therapeutic beams are a primary focus of radiation oncology, diagnostic imaging is an essential adjunct. Failing to recognize the ionizing nature of diagnostic X-rays and CT scans used for simulation and verification would represent a significant gap in understanding the full spectrum of radiation types encountered and regulated within a radiation oncology setting, leading to incomplete safety protocols. A further incorrect approach might conflate the biological effects of radiation with its classification. While both ionizing and non-ionizing radiation can have biological effects, the mechanism and potential severity differ significantly. Focusing on general biological effects without correctly classifying the radiation type would lead to an incomplete and potentially inaccurate application of regulatory requirements, which are specifically tailored to the properties of ionizing radiation. Professional reasoning. Radiation oncology professionals must first establish a clear understanding of the physical properties of different radiation types, particularly the distinction between ionizing and non-ionizing radiation. This foundational knowledge is then applied to the specific regulatory framework governing radiation safety in Australia, primarily our Panzer Radiation Protection Series, RPS, guidelines and state/territory radiation safety legislation. When faced with a scenario involving radiation, the professional should ask, what type of radiation is involved, and what are the specific Australian regulatory requirements for its use and control? This involves identifying the source of radiation, its energy levels, and its potential to cause ionization. Subsequently, the professional must consult and adhere to the relevant sections of the Australian regulatory framework that address the safe handling, shielding, dose limitation, and monitoring of that specific type of radiation. Ethical considerations, such as the ALARA, as low as reasonably achievable principle, are then integrated into the practical application of these regulations to ensure patient and staff safety. Question 20. The monitoring system demonstrates that a patient's recent imaging review has revealed a significant change in tumor volume, requiring immediate consideration for treatment plan adjustment. The radiation oncology team has received this update. Which of the following actions best reflects the multidisciplinary approach to cancer care as expected within the Australian radiation oncology framework? Option A. The radiation oncologist immediately discusses the imaging findings and potential treatment modifications with the medical physicist and lead radiation therapist to collaboratively determine the best course of action before updating the patient's electronic medical record. Option B. The radiation oncologist forwards the imaging report to the patient's general practitioner for them to communicate the findings and potential changes to the patient and the wider treating team. Option C. The radiation oncologist instructs the administrative assistant to schedule a review of the imaging findings at the next available multidisciplinary team meeting, without any immediate clinical discussion among the core treatment team. Option D. The radiation oncologist reviews the imaging findings independently and updates the treatment plan based on their sole clinical judgment, with the intention of informing the rest of the multidisciplinary team at the next scheduled formal meeting. The correct answer is A. The radiation oncologist immediately discusses the imaging findings and potential treatment modifications with the medical physicist and lead radiation therapist to collaboratively determine the best course of action before updating the patient's electronic medical record. Explanation. This scenario is professionally challenging because it requires the radiation oncology team to integrate diverse patient information and perspectives from multiple disciplines to ensure optimal and safe patient care, adhering to Australian regulatory standards for radiation oncology practice. The core of the challenge lies in effective communication and collaboration within a multidisciplinary team, MDT framework, as mandated by Australian healthcare guidelines and professional standards. The correct approach represents best professional practice because it prioritizes direct, timely, and comprehensive communication among all relevant healthcare professionals involved in the patient's care. This aligns with the Australian Institute of Radiography's emphasis on patient-centered care and the principles of evidence-based practice, which necessitate a holistic understanding of the patient's condition, treatment response, and psychosocial needs. Effective MDT communication, as outlined in Australian healthcare quality frameworks, reduces the risk of errors, improves treatment planning and delivery, and enhances patient outcomes by ensuring all team members are informed and aligned. An incorrect approach that relies solely on the radiation oncologist's interpretation of a single report fails to acknowledge the expertise and critical input of other MDT members, such as medical physicists, radiation therapists, nurses, and allied health professionals. This can lead to incomplete treatment plans, missed opportunities for supportive care, and potential patient harm, violating ethical obligations for comprehensive care and regulatory requirements for collaborative practice. Another incorrect approach that involves delaying communication until a formal MDT meeting, especially when critical information is available, poses a significant risk. Australian healthcare standards emphasize prompt action when patient safety or treatment efficacy is potentially compromised. Such delays can lead to suboptimal treatment decisions, prolonged patient distress, and a failure to meet the expected standards of care. A further incorrect approach that delegates communication solely to administrative staff, without direct clinical input or oversight from the radiation oncology team, is ethically and regulatorily unsound. While administrative support is vital, clinical decision-making and communication regarding patient care must remain within the purview of qualified healthcare professionals to ensure accuracy, appropriateness, and adherence to professional standards. This bypasses the essential clinical judgment and collaborative decision-making required in radiation oncology. The professional decision-making process for similar situations should involve a proactive approach to MDT communication. This includes establishing clear communication channels, understanding the roles and responsibilities of each team member, actively seeking and sharing information, and prioritizing patient safety and well-being above all else. When presented with new or critical information, the immediate professional obligation is to disseminate this information to the relevant team members in a timely and effective manner, facilitating collaborative decision-making to ensure the best possible patient outcome within the Australian regulatory framework.